So I'd like to welcome you to this next session this morning, our second session on pressure ulcers. So for this session we have got, it's pressure ulcers, positioning is more than repositioning. So I'd like to welcome Jenny Davis, who is an advanced tissue viability nurse specialist at Southern Health NHS Foundation Trust. And her presentation is going to be on how contractures affect the development of pressure ulceration and measures taken to prevent this in a care home setting. So thank you, Jenny, and please put in any questions in the question and answer box, and we will address them at the end of the session.
Pressure ulcers, positioning is more than repositioning. So how contractures affect the development of pressure ulceration and measures taken to prevent this in a care home setting. So our session objectives for this morning is we're going to be describing the event that I was involved with, defining what a contracture is, describing how a contracture increases the risk of pressure ulcer development, identify 3 examples of how to incorporate prevention moves into everyday care, and to identify training ideas for all staff and patients to raise awareness. So the background to this is that I was working as the lead clinical trainer for a large local authority. Within that area, there were 17 nursing and residential homes throughout the county. It was quite a wide geographical area as well. Contractures were increasing, but they were not being recognised within the homes by the staff. And they were also unaware of the pain associated with contractures for those individuals. It was also assumed that they were an inevitable part of ageing. They knew that their residents had rigid limbs, they were unable to move them, but they didn't realise that they were actually called contractures, and they thought that that was just part of the ageing process. So our main focus was then how to actually raise awareness, how to give it a definition, and to ensure that staff had an understanding of what was actually going on with some of these residents. So we decided to hold a clinical event for staff within these care homes and nursing homes. And what we did was that some of our preliminary meetings, we had to really involve the senior teams and get buy-in from them. We knew that we couldn't do this on our own, and that it had to be a team effort. We also wanted to have this as a full day. We know that it's also much easier for staff to be released for a full day rather than a few hours at a time. And this was agreed in the initial stages. We also invited specific staff roles to the day. So rather than just having the senior nurses or the managers attending, we wanted to make sure that actually everybody was involved, because we know that this is very much a day-to-day care issue, and we needed to have everybody involved within this day. So we had specific numbers of staff for each home invited. So we had carers, we had activity coordinators, we had nurses, we had other senior staff, we did have managers as well. But we did have quite clear restrictions on exactly who we wanted to attend. But we wanted to also make it attractive, so that they actually wanted to come. So we did offer them a free lunch and various other bits like pens and post-it notes, of course, because who doesn't love a free pen? So we had a very attractive offer for everybody to come. And we actually called it I Like to Move It, Move It. Some of you may know the film Madagascar, and it was a really sort of fun way of trying to think about what we actually wanted to get across on the day. We also asked the staff that were attending to come up with ideas for the names of what we were going to call them. So we had champions for everything within the homes. We also had link roles as well, and they were felt that it was always a champion this and a champion that. We didn't have anything sort of particularly individualised. So one of the teams actually came up with the name of a Move It motivator. So from then on, the staff that attended were called Move It motivators, and each home was actually had designated members of staff that were the Move It motivators for the home. And as you can see, we have got the meerkats and lemurs, which again made it a bit more fun for the staff. So with the title of the event set for I Like to Move It, we then had to come up with some really key themes that we wanted to actually include within the day. And one of the most important things that we wanted to do was to look at how the teams were working together and communicating. So we thought that some of the sessions would have to be engaging for all of them anyway. We know that that this particular group of staff are very, very active. They're not used to sitting for long periods of time. So we had to make sure that everything was really sort of engaging and interactive for them. The first activity that we actually had to get them all moving and get them interested and get them talking was a bit of a silly activity, and they had to make hats out of toilet rolls and sellotape to then balance some plastic fruit on their head, which again was great fun, as you can see. And it just got them to work together without any hierarchy, and communicating those ideas with each other. It's a lot of fun. What we also had was other sessions throughout the day, including things like pressure mapping. So we were very lucky to have somebody come along with a pressure mapping equipment for the bed and the chair, and they actually got to really see how that can affect the individual's pressures. And we also had several OTs coming along as well to do some repositioning and give them ideas on how they can actually support some of their residents in their moving and their repositioning skills. We also had a session that was a very personal session. We were quite lucky to have a member of staff able to share her story in an incredibly moving way. She actually had a relative with really quite severe contractures that had developed elsewhere in the country, and this lady was able to describe the impact that it had had on this family member and on the wider family, and she said she described this with such passion and such clarity. It was really quite moving, and it had such an impact on everyone within the room. I mean, we had about 120 people attending for the day, and each one of them was completely had their full attention. It made such a difference for them. And while we do obviously recognise that this is quite a serious condition and so on, it did have to have an element of fun, because we wanted everybody to come away from the day feeling quite inspired and able to go away with the key messages that we wanted them to have, but also to talk about it with others, with other colleagues, with their family members, even with their friends. So we had to start with the initial definition of what exactly is a contracture. So bearing in mind that a lot of these staff members didn't know that as a term. They may well have seen it on some of their residents, but they didn't know that it was actually a condition. And so the definition that we have is here from the Oxford English Dictionary, which is a shortening and hardening of muscles, tendons, or other tissue, often leading to deformity and rigidity of joints. My colleague Gill will be expanding on this a little bit in the next part of this session. And then we did a session on how that actually feels for the residents. So this is a bit of a health and safety disclaimer. So if you do have any neck or back problems, please do either don't do this or stop if you're feeling uncomfortable. Okay. So first of all, I'd like you to try and sit a bit wonky in your chair. So sit on one of your buttocks. and then squeeze your legs together as hard as you possibly can. Okay, and turn your legs in one direction, and then twist your shoulders in the opposite direction, and keep squeezing those legs together as hard as you possibly can. Keep squeezing. Next, push your back into the chair. If you've got a back on your chair, keep pushing that and twisting and squeezing your legs. Keep squeezing as hard as you possibly can, and keep squeezing and keep squeezing and keep twisting and keep squeezing, and just hold that position. Keep squeezing and just hold that for a few more seconds and see how that actually feels. If you think about where those extra pressures are, see how uncomfortable that feels in your thighs, in your legs, in your back, and relax. So we did that as a bit of an exercise with all the staff. We asked them, again with the health and safety disclaimer, we asked them to just pay attention to how that actually feels for them, and to understand that these residents that have got a contracture are feeling like this 24 hours a day. And again, that gave them a really good insight into how their residents might actually feel. We then looked at how this can affect an individual's skin conditions and how it can increase the risk of pressure ulcer developments. As I'm sure most of you know, obviously if somebody's got a contracture, they are likely to have a decreased movement. They're likely to have changes in their body position, so whether they've got some wind sweeping going on, which is where your legs are both moved to one side. It could be that actually it's really difficult to change their position simply because of the contractures that individual has. They will also have pain on moving and at rest. And again, as we know, if you've got somebody who finds it very uncomfortable to move and change their position, they're going to be much more likely to resist and to not want to do that or engage. And then obviously if you've got any body parts pushing together, as we know, any areas of skin that are going to be pushing together are going to be occluding, and that risk of pressure ulcer development is going to be much greater. So some of the sessions that we had were much more practical sessions with ideas of how movement could be incorporated within everyday activities. And we're thinking particularly around their morning washing routines, their dressing routines, and so on. So everybody that attended was given a small little stress ball, and they were to have a bit of an idea of what they could do to work with their residents to help keep their hands and their fingers mobile, keep them using their limbs. And to also include the family within this. So a family often want to be able to do something to help their loved ones, and often they do feel quite helpless. But if we can encourage them to be part of this process, then it's really, really useful. Using larger beach balls for bigger muscle groups. So again, each home was given a couple of big beach balls that they could use within different ideas, not just within that daily activity session that they might have with the activities coordinators, but even before lunch, while they're waiting for their breakfast, or they can actually have big beach balls that they can pass around between the residents, and get them having a bit of fun with it as well. Obviously, COVID has changed things slightly over the last 18 months to 2 years, so they have had to be a little bit creative. But this is all pre-COVID. We were also talking to them about laying the individual flat frequently. Again, they seem to be quite keen on having individuals sat up and being in a comfortable position. Absolutely. People tended to resist laying their residents down flat and stretching them out a little bit more. So we were really encouraging that as part of their care. And we also really highlighted the importance of following the OT and the physio plans. So it's absolutely key for keeping function and preventing their position from deteriorating. So by using photographs with the equipment in place so that they can get the same positioning in the same way. Some of the things that we discovered during the day and that the staff were really quite keen to discuss was that actually the recognition that first of all what a contracture is, but the understanding that they had that prevention was always better than cure. We know that although there are some procedures that can sometimes help, they're not always overly successful. So prevention, same with anything, is always better. By having photographs on admission, discussions with the family and friends, any previous placements that they might have had, any hospital admissions if they've been in hospital for long periods of time, having that communication with the hospital and being able to discuss the positioning of their bodies, again, was really essential. Any communication with all staff and other allied health professionals, again, is really key to be able to prevent any deterioration in body position. And then thinking large and small, active and passive movements. We know that passive movements may not necessarily be taught specifically, but they are still incorporated within everyday movement. Even the simple task of assisting someone to put their arm into the sleeve of their jumper is still moving. You're still stretching out that limb. And then being creative, so having fun within that situation, and encouraging your residents to work with you. And by doing that, again, we say making every contact count. This is not the responsibility of one person within the home environment. It's everybody's business. And having fun, really. I think that was the most important thing, certainly from the day, is that you know, it is about remembering that we can make this a lot more fun and a lot more engaging for staff and residents alike. So moving forwards after the event, all homes that were unable to attend, of which we only actually had one that was unable to attend due to an outbreak, but they were provided with all the information and the equipment and the beach balls and so on. And they were also asked to name their MIMs, so the Move It motivators, and they were all of the MIMs were actually encouraged to share their achievements on a regular basis. We actually had twice yearly meetings, obviously again pre-COVID, where they were able to share that and come up with other ideas that they'd had since. We were also doing audits to monitor the number of contractures within that sector, again pre-COVID. But to look at, first of all, how many contractures we had within each home, but then also what was happening after the event. Did we find that we had an increase in number, which we did because we had the recognition there, but then we were hoping to see a decline and a decrease in the number of contractures. As a bit of an additional note, just before I finish, I'd just like to say that I was actually contacted by one of the carers several months after the event, who said that she had a resident that she noticed that her hand had started to contract in, and she remembered this day, and she was really quite enthusiastic, and she said that she started giving her some very gentle hand massages in warm water, a bit of emollient cream, and just did that with her every day, every morning. She encouraged her family to also work with her, to do some exercises with her, just very, very simple hand exercises. And she found that actually within approximately 2 or 3 weeks, her hand had actually returned to full function, and she was able to go back to using her knife and fork at lunchtimes as well. So she said it was incredible to be able to see this and witness this during these few weeks, and it was all because of the event that she'd attended a few months previously that she'd remembered. So on that note, I'd just like to leave you with my final saying, which is I do like to move it, move it. Thank you.
Thank you very much, Jenny, for that brilliant presentation. So we're going to have questions at the end of the next session for both Gill and Jenny. So please keep adding questions into either the question and answer or the chat box. So without further ado, I'll just introduce our next presenter. It's Gill Grist, who is an occupational therapist, ACP. She's a seating and therapeutic positioning specialist and tissue viability AHP at Southern Health NHS Foundation Trust. And she will be talking about posture management and therapeutic positioning to help prevent and treat pressure ulcers. So thank you very much.
So session today, what I'm looking to hopefully do is raise awareness that posture management and pressure ulcers are completely inextricably linked. What I'd like people to be able to do is just be able to describe what posture management is and be more aware of the therapeutic positioning that can be possible in order to prevent pressure ulcers. So a bit like contractures, there's no formal definition like you have got for pressure ulcers. So my stab at it really is a person-centered, holistic clinical field of practice which aims to protect an individual's body shape in order to prevent their body systems from coming to harm and to optimize the potential for the person to carry out activities of their choice. So there's a bit nursey and a bit OT, but hopefully it's holistic and people will understand that. And obviously the body systems in particular we're looking at today is the skin, but it is much wider than that. Okay, and what I like to do when I'm sort of teaching is have a little bit of a foundation for people to build on, to understand what posture management is, so sort of a bit of a visual on it really. So what I've come up with really is that, I'm going to move this little thing out of the way here, 24-hour posture management. And I see it as physics meeting anatomy, which affects physiology. And I hope that you can see there's obviously a correlation here with regard to the development and the risk factors of pressure ulcer. And I think a lot of the risk assessments that are out there are very good at looking intrinsically, but I think there's a bit more that we can do extrinsically. And I think that's where we have, if we could have interdisciplinary working, so that's nurses, physios and OTs working together, I think that would be the ultimate in terms of getting better outcomes for our patients. Just popped a couple of official definitions which you may want to visit later on. Bit of a picture warning. So why does posture management matter? We know that people die from pressure ulcers. We know that people die prematurely from body shape changes. This is quite well researched and documented within learning disability. But I really want to raise awareness that this is, I see it happening with our older generation as well. And I think particularly for our care home residents, where therapy seems to drop off as soon as they get into a safe place. Okay, so just want you to see here, there's a long list of correlations with tissue viability and pressure ulcers. So if you've got, for example, somebody who's not in a position where they are able to eat and drink, so it makes them have swallow problems because they're sat in their chair or in their bed appallingly and they keep choking and then it puts them off eating, then obviously that then increases their risk factor for nutrition and hydration, which then can lead to an increase of pressure ulcers. So all of these in this list here, there's a little line, tissue viability, posture management, tissue viability, posture management. So if you want to revisit that later on, then obviously you can explore that for yourselves in a bit more detail. But as you can see from that long list, there's a physical, psychological and emotional effect when people have body shape changes. I'm just going to start with the really basic stuff to start with, because we see it all too often. Obviously, this is a fit young colleague of mine who's been mocking up a couple of positions for me. So you can see in terms of if his chair was too high, you can see how he is loading his back and his buttocks, and there's shear and the floor there as well. And indeed, if he was sitting in a chair which was too low, you can see the loading here is not optimized in terms of surface area. So that then reduces the amount of time he would be able to sit before getting a bit of redness. The same goes for if a chair was too wide, people tend to lean to one side, and that obviously puts more pressure on one buttock. Okay, so this is quite a common posture which I see out there. People that have developed kyphosis for whatever reason. If this isn't accommodated, this is the sort of position that people end up with. And you can see that the bony prominences will be more prominent, which will increase the risk there. You can see that gravity is pushing him down, so his head will be far heavier. But because people want to see where they are, he will be lifting his head up and giving himself that chin poke, again, which we see quite frequently. And when that happens, you then get, obviously, structural changes in your throat, which may then affect your eating and drinking. But also, what I really want to highlight, there's a lot of interesting work going on around respiration. So you will see that leaning down here will then be taking away his diaphragm movement. So he won't be able to get that full inflation and deflation of the lungs. So again, we've got the importance of our saturation levels. If a person is left like this, where they have got potential, because obviously people have fixed postures, but where people have postures which can be accommodated and supported into a more open position, we have seen through some research that you can increase their oxygen saturation levels. This again is another typical presentation. It frequently happens when people become less mobile, and you then start getting shortening of the hamstrings, which I'm sure you will know insertion points are at hip and knee here. And this can be through lack of movement, but obviously it's a bit more complex than that. You have got people with spasticity, parotonia, all of those type of things as well. But where it is due to lack of movement that these contractures are forming, then we need to be looking at how can we use gravity as a therapist to prevent this type of thing happening here. So we all have a dominant side. What we tend to do is for our legs to fall over, and I'm sure this is very familiar to all of you. You can see what that's doing to his diaphragm. You can see the loading will be on one side here. You can see shear and problems, increasing risk factors for his tissue viability here as well. So this is just an example of a patient a young man that I saw. This is a fixed contracture that he has here. We did try various different pillows, which obviously is always the starting point, but they weren't strong enough to support his legs in an aligned position. But these contractures were permanent, but this rotation was not permanent. So that's what we had to work with, really. And what we did was use some specific positioning cushions to accommodate that contracture. What we wanted to do was prevent any more shortening, optimize any potential for extension, but obviously to offload the heels as well. And he went on to feel much better after this positioning. He had a much better night's sleep, which then actually made him perform better, or he said he performed better at work because he'd had a better night's sleep and was just feeling more energetic. So that very simple setup made a huge difference for this young man. Now, I know that there's quite a lot of talk around what does 30 degrees of side lying, what does that mean? I've certainly seen lots of different pillow positioning to try and achieve 30 degrees. And I kind of think that there's no one right way for somebody to be put into 30 degrees because all our bodies are different. So I think in terms of how to, you aim towards 30 degrees, but the point is what we're wanting to do is unload the sacrum coccyx, for example, but not too far onto the trochanter that you then shift the problem elsewhere. So I think the 30 degrees, it would be lovely to have a concept put together in terms of what does that actually mean, rather than it just being an empty number and people stuff pillows in to try and get to the so-called 30 degrees of sideline. Oops. Okay, so obviously key is absolutely, comfort is absolutely key. If people are in pain, obviously they become reluctant to move, you get sustained pressure. Obviously, if people are on medications to manage pain, then that can sometimes compromise food and nutrition. And some medications like steroids make the skin more papery. So pain is a really big part of posture management. Respiratory function will always trump out on everything else in terms of what the most important thing is to achieve. But then what we are looking to do is comfortably support somebody in the best position that they can achieve. And if we can sneak in a bit of therapeutic positioning to help improvements, if that's possible, if it's not sort of more neurological, but more extrinsic factors like the right chair and the right gravity direction, then really that's what we're looking at for posture management. There we go. So contractures, we haven't got time to go. Contractures is a massive problem out there. And just to make you aware, there's a bit of work going on at Bournemouth University. We've got a PhD student testing out a risk assessment form, but what they have found so far, this isn't written up yet, but I think she's in her third year. But what we actually found was that a lot of people say it was about lack of mobility appearing to be the highest risk factor for avoidable contractures, which links very nicely into what Jenny has just presented to you with her move it motivators. But obviously with contractures, you've got increased bony prominences. It's obviously it's often really painful for people to move. And I know I've been out on visits and people have had to have pain meds before their pads can be changed. And it's really very overwhelming to see the level of pain and discomfort that people are in because of contractures. So I think we've got to do a lot better. And that's one of my soapbox moments. So there we go. But not forgetting moving and handling. In terms of positioning, we often see this first posture, people being plopped into their wheelchair or armchair without being optimized from the get-go. So obviously you've then got our ever familiar shearing going on, but also look at that poor person's respiratory function compared to that. So if you need to rehoist somebody 3 times or whatever, as long as you optimize this symmetry of the person's body, so pelvis as level as possible, shoulders as level as possible, then again, we can hopefully work together in reducing the risk factors for pressure ulcers. Again, this is another soapbox moment for this really. In my opinion, we have actually got much better knowledge now to work with solutions that can prevent pressure ulcers. When I'm talking about prevention now, I'm actually talking about predictable harm, because I think that comes across as a little bit stronger. And certainly when we are looking to provide equipment, the main aim in posture management is to obviously optimize, but also to prevent this predictable harm. Repositioning, everybody who is not mobile or not mobilizing as they used to needs to be looked at much earlier, and for people to start looking at an individualized posture and positioning care plan, which obviously then can help with pressure care management. Ideally, we want to be having photographs, because where you've got carers come and go, they won't necessarily recognize that, you know, that a lady's arm hasn't always been like that. You know, this has happened, you know, literally within the last week. Perhaps she's acutely unwell. We know that tone increases when people have UTIs, chest infections, that type of thing. And also just want to highlight that specialist mattresses and cushions do not replace the need for regular repositioning and care. I think that point is out there now, but I like to repeat it. And another thing which I've noticed recently is about a lot of our people that we look after have lost weight. And what I'm seeing is a lot of loose skin, and people will smooth out clothing and bedding and that type of thing. But what I've noticed is with people's skin is there's that drag and that fold over, and I've seen wounds happen because there's excess flesh, and one bit of the flesh is acting on another bit of flesh, and that's like a bit of a tourniquet. So again, I'm looking at what we can do to help there a bit more. I know sort of moving somebody away from the backrest, even if you've got a fancy bed or chair that is supposed to stop that drag, I'm encouraging people to move, particularly the back and the body after they've been repositioned in a bed or mattress. And finally, just to let you know a little bit of work that I'm doing locally, continuing to build on sort of local resources. I really would like to have a capability framework, and I've split the training up into different modules for different complexities of need. So it's around the patient. And my hope really is that health education or the like develop an inclusive strategy. So it includes our elderly non-mobile patients. Scotland have got an excellent one, but it is quite focused on our younger generation with learning disabilities. Thank you for listening. So
really, really interesting sessions from both Jenny and Gill today, and we've got some brilliant conversations going on in the chat box. I'll start with, there's a question from Gabriella, I guess it's to either of you. She's saying that she's got a resident at the moment who's very contracted, and was asking, is there any medication that can be used to help them feel more relaxed and comfortable? Currently he's on pregabalin and cocodamol, but he also is epileptic with kidney problems. So is there anything there that you can?
Absolutely. I think people need to be reviewed regularly. There are some medications that can help, but it's also about sort of looking at the whole person intrinsically and extrinsically. If you have got somebody who has got anxiety, who is lonely, who is low in mood, what people often do is hold their bodies. We go into this like fetal type position, Also, if somebody is trying to balance because they are a bit contracted and they're not fully supported, again, that can increase tone and then that can increase pain. So it's about having the right eyes looking at that patient and then signposting in terms of their medication review, but also what's going on in their lives extrinsically as well.
Thank you. A really interesting comment from Inga here we've got. So she's saying there are so many things to look at. It could be spasticity and not the crack contracture, but once the contracture is established, it's extremely hard to deal with. And so she was saying she's worked in neuro rehab for 4 years and they use a lot of splints and soft casts. But where she worked previously, it's almost non-existent in nursing homes. So why is it so difficult to get physios and occupational therapists in nursing homes to help prevent contractures like this, where it's so much more better managed in rehab units?
Absolutely. And I think it is a postcode lottery where that's happening. There is a lot of drive from the enhanced care home work that's going on currently, that our care home residents aren't forgotten because they can be put in bed and kept safe. These people are entitled to have as full a lives as possible, but there isn't the commissioned resources. And I feel that we are neglecting that client group, and hopefully by the time I'm in a nice nursing home, we'll have a good therapist, nurses, and a proper interdisciplinary team working together.
So I suppose with Jenny, you were talking a lot about the training that you were delivering, but how much of that is towards actually the use of splints and devices to prevent these contractures or minimise them?
Yeah, I think certainly the training that I was doing was much more generic. We didn't have the luxury, I suppose, of lots of equipment and lots of professionals coming in to be able to give that support for these residents. So it was very much more about the prevention. I'm not an OT or physio. I am only a nurse, and the same with most of the staff within the homes that we were doing this work with. It was much more about the prevention, and I noticed a comment about we need to be looking at the prevention rather than parking the ambulance at the bottom of the cliff, which I quite liked as a comment, because we're not preventing these sorts of conditions from happening in the first place. And I think that goes back to the very beginning of the recognition of what it is, and what can potentially happen, and what anybody can do to prevent it. It's not a case of it's only up to the OTs or it's only up to the physio. It's all of our business. It's everyone can make a difference, and that includes the relatives who often do feel quite helpless when they come to visit their relatives. Get them involved, and use them as well.
And there was a question from Ina for you, Jenny. She was asking, do you measure, do any range of movement measurements or anything like that, or any other measures to show improvements with your programme?
No, it would be lovely, but that would absolutely be usually down to the OTs to do those sorts of measurements. We wouldn't be expecting the care staff within the nursing or residential homes to do that. And I think, to be honest, they'd probably be a bit frightened if they had to do something a bit more formalised. This is much more about that initial prevention and making it part of their everyday care and support for that resident.
You need the training in order to do that range of movement safely and correctly, accurately.
We've had another question for Gill. Can you comment on wheelchair bases that often hammock people, and what we can do to resolve this, especially if the wheelchair services are under such pressure and unable to review or replace wheelchairs as needed?
So hopefully they're not just sitting on the base of the wheelchair without a cushion on it. If that is the case, then you need to get that reviewed pretty quickly. The hammocking should be taken up when the cushion is actually in place. If somebody's cushion is not suitable for them, then it is unfortunately a case of working with the wheelchair services to get something out there because of the risk of tissue viability issues. And I know that some wheelchair services are now doing like a self-referral where it is just the base cushion which is worn out. I mean, foam usually only has a lifespan of about 5 years, but we all know people that have had cushions out there for, you know, donkey's years, and they're pretty ineffectual, really.
Brilliant, thank you. I think we've got time for one more question. So another one for Gill from Inga. So she's saying pressure ulcers are classed as healthcare associated injuries or harms because they are preventable, but if contractures are also preventable, as are pressure ulcers, should they be classed as a healthcare associated harm?
The difficulty with contractures is there are some which potentially could be preventable. So where you've just got somebody that needs repositioning regularly to give them a change of positioning, because obviously we know that if a limb is held for a sustained period of time, that's when you get the changes at cellular level. But if you have got neurological impulses going to these muscles, then it is the intrinsic, and sometimes they can't be avoidable. And I think that's where the struggle is, because we know as therapists, because I've had people straighten out, you know, before my very eyes when people have thought that they were permanent contractures. And actually I just used gravity as my therapist. But there are other people where it's neurological, and you know, but it's making sure we don't miss those ones that have got an opportunity to have preventable contractures. So yeah, very good point though.
Brilliant. Well, that's come to the end of our session now. So we've got another 10-minute break, and then we'll be restarting again in half